is occluded too, but in the follow-up at 18 months, you see that it's the pericallosal arteries started to fill again, though a little bit smaller than the preoperative size. Secondary to flow remodeling effect of these treatments, the angiographic results may differ from those in the endosaccular packing and need to be described. This is why we ended up describing a new aneurysm occlusion classification after the impact of this flow modification. Basically, it is a modified Tuaraimon classification with its classical class 1, 2, and 3, complete occlusion, neck filling, and incomplete occlusion of the aneurysm. However, when there is an integrated branch of the aneurysm treated with flow diverter, depending on the patency of the integrated branch, we describe subgroups 1A, B, and C. If it is fully patent, then called A. If it is reduced in caliber, it is called 1B. If there is no antegrade filling of that branch, we called it 1C. Class 4 is aneurysm filling at the immediate post-operative result out of the concern of this talk. And class 5 is very important, especially for the bifurcation aneurysms, which is the stable remodeling due to flow modification, which describes the filling in the neck region just with the continuation of the integrated branch, unchanged or reduced in the two consecutive angiographies. We're going to see examples. Flow remodeling concept not only caused a paradigm shift in the sidewall aneurysms, but also inspired us in the treatment of complex bifurcation aneurysms. This is a typical example that we show. which very much resembles the PCOM mannerism that I showed. When you change the direction of the image, you can easily see that the MCA bifurcation aneurysm very much like the sidewall aneurysm with an integrated branch. So why not putting a flow diverter at the neck? We were fan of stent-assisted coiling and treated very complex bifurcation aneurysms with dual stents or single stents, using even large profile stents. Very good results, very low recanalization with dual stent assistance. And after the introduction of the lower profile stents, it became easier and safer, and we treated many complex bifurcation aneurysms as well. But are we going to continue to do such complex treatments, or we switch to use flow diverters in large neck, in wide neck aneurysms at the bifurcation? Here are a bunch of aneurysms that we treated using flow diverters. Some of them we may not have treated otherwise without a flow diverter, as in the, for example, this one. We may have treated with dual stent assisted coiling, possibly, as in these ones. However, possibly it would have been much more difficult and more challenging. So now, from now on, I'm going to talk when and how do we treat bifurcation aneurysms with flow diverters. So first of all, the treatment concept and target needs to be understood. So philosophy is to simplify the treatment. Flow diverter is to be placed to extend into the non-dependent straight trunk. It's a very easy, straightforward treatment, and you see in the control, 1-year control, the integrated branch is fully patent, the aneurysm is gone, and 2 years stable and 3 years very stable result. The target of simplicity is the same for ACOMs. Actually, I'm going to mostly show ACOM and MCA examples because the distal aneurysms will be covered in the next session, I know. Anyway, in this ACOM aneurysm, flow diverter is to be placed into the straight, non-dependent branch, easier A2 trunk. And in the follow-up, the aneurysm is gone, very nicely reconstructed ipsilateral anterior cerebral artery. The contralateral A2 is not filling. However, when we look at the pre-treatment and post-treatment angios, we realize that because of the flow demand, the contralateral A1 got bigger, so that the contralateral A2 is filling from the contralateral ICA, from the ipsilateral A1. So no need for the flow through the ACOM and the contralateral ACA. If both trunks are relatively easy, we always choose the trunk that is larger, or we create more significant geometrical modification. In this case, we placed the flow diverter to the inferior trunk, and here is the 1-year control. You see that the superior trunk is a little bit smaller but patent, and the bifurcation is very nicely reconstructed, which is 1B occlusion according to our new classification. If both trunks are difficult or dependent, In the ACOM region, we choose the larger trunk to put an easier trunk to put our flow diverter. In this one, it's laterally 2 to A1, and you see a 1-year control, very nicely reconstructed. The aneurysm is gone, and same hemodynamic effect. The contralateral A1 got bigger in the 1-year control to provide the flow demand, so that no less flow demand from the contralateral side. Another ACOM complex aneurysms, 2 blisters had a rupture story, and we placed a flow diverter to the most straight orientation, and in the control, the ACOM complex is very nicely reconstructed. The blisters were gone, and the branches are patent. At ICA terminus, it is less complicated and easier to understand and decide. We always put the flow diverter to M1, never jail MCA in our experience. And when there's the flow diverter placed in the M1 to ICA, it reconstructed the aneurysm very nicely, and you see the ICA termination aneurysm is occluded with the branches spared very nicely, including DA1. The second issue I would like to stress on is the anti-aggregation. It is very, very, very important for the bifurcation aneurysms. In such a big MC aneurysm, while it is being reconstructed with the flow change of the flow diverter treatment, it is very important to keep safe from the thromboembolic event. And we can only rely on the newer generation drugs, that's to say prasugrel and ticagrelor, for that purpose. The clopidogrel is not reliable, having resistance, at least in our population, it's close to 1/3. And also, when there's a very important branch taking off from the aneurysm, in this ACOM aneurysm, the subcallosal artery is originating from the aneurysm sac. So it is very important to keep this vessel patent with a very good anti-aggregation. You see at 1 month, the aneurysm is gone, the branch is patent, and 6-month control, same, aneurysm is gone, branch is patent, and you see the 1-year control DSA very nice patency of the subcallosal branch, as well as the contralateral A2. And in this MCA aneurysm, for example, new generation anti-aggregation, please go on with stent-assisted coiling or with other techniques, because it can be treated with stent-assisted coiling, for example, or possibly with intrasaccular flow modifiers, though the angle is a bit challenging. But with good anti-aggregation, flow diverter provided a very nice result, that the aneurysm is gone, the jailed inferior trunk is filling in a retrograde fashion, but so fast that you cannot appreciate if you do not look very closely. And 2 years control, you see the nice reconstruction of the bifurcation, aneurysm has gone, and very good result. The other issue is post-treatment follow-up. Morphology expectation needs to be adjusted according to the new understanding of the aneurysm occlusion or flow remodeling concept. For example, this MC aneurysm where the flow diverter was placed, we do not call this as a failure or remnant because it stays same. We see modification to keep the flow in this branch because there is a flow demand. Another example, an MC aneurysm, and at 1 year control, you may say that this is a failure because there is a piece of aneurysm filling. However, when we see that it stays same and it doesn't change, and this is the part necessary to keep the flow into those branches. So it's a class 5 occlusion, which represents the stable remodeling. Another example, flow diverter was placed. Very nice reconstruction. Are we going to call this part as a remnant? Actually, no. 5 years CTA, stable result, nice healing reaction. Uh, Another example, a challenging aneurysm to treat with endovascular, but flow diverter created a very nice result. Are we going to call this part filling as a neck remnant? At 5 years, it stays same. It is necessary to keep the flow, and this is a flow modification, so class 5 occlusion. It may take, the flow modification may take a long time, as in this case, 6 months, superior trunk gone, aneurysm filling, terrible result. 12-month aneurysm filling, superior trunk started to fill, still terrible result. After discontinuation of the clopidogrel, this is one of the first cases, you see at 18 months, excellent result, nice reconstruction of the bifurcation. We have even 10 years CTA on this patient. And sometimes it works very fast. This is a case from 2020 virtual live WLNC live workshop, and the flow diverter was placed. And see, this is the 1 month control. I took it from Saruhan, and very nice reconstruction of the aneurysm, not filling, the sac was not filling, only we see the enlargement of the origin of the jailed branch. However, it may even take 3.5 years. This is a case of Dr. Ushla. He was patient enough to wait for this patient, but eventually he got a very nice reconstruction of the MCA aneurysm. So last word before coming to conclusion, in order to get a safer treatment, we oversize like 1/4 or 1/2 of a millimeter according to the largest M1 size, and the device opposition to the wall and to the convexity is very important, and we go for 48 wire at bifurcations. And here are our results till 1 year. These are the results of MCA bifurcation aneurysms till 2019. We have 96% aneurysm occlusion, no mortality, 3% permanent neurologic deficit. In ACOM aneurysms, less number of patients. Till this year, 31 ACOM complex aneurysms, no mortality, 1 morbidity, and except for one still filling aneurysm. 4% all are occluded. And my conclusion is use of flow diverters in the treatment of bifurcation aneurysms not only simplifies the treatment and makes it more doable, but also may make a challenging or untreatable aneurysm treatable in selected cases. However, this does not imply that because we have the hammer available, all bifurcation aneurysms are nails. Thank you for your attention, and I hope it was beneficial. Thank you.
Well, fantastic, Isi. I wish have you with us in this SIMI, but next, please. So has been very impressive, very nice. We will face probably a very nice discussion. That meeting is called hybrid because we have neurosurgeons and interventionalists here with us. So we will require some opinions about the topics. Just to start, are you going to stay with us, Isi, for a while?
I can.
Okay, great.
No problem.
Great. So, Angel, can you start? Angel has one case to start with our discussion. It was a very complicated case that we managed. As always, we have to understand something and we have to learn something. So let's see what we did learn with that case. Ángel, por favor.
Ok, gracias. Una paciente con un aneurisma incidental de la arteria cerebral media izquierda que fue tratado inicialmente en otra institución con coils de platino. La paciente años después regresa con una hemorragia subaracnoidea, Fisher 4, Hantiges 4, y se hace una embolización con coils, como ven en la imagen de la derecha. Esta es la angiografía diagnóstica después del sangrado. Ven que los coils que se habían originalmente colocado están completamente deformados, empujados al aneurisma, lo que ya está haciendo sospechar que se trata de un aneurisma disecante de la arteria cerebral media, donde hay un daño del endotelio, lo que justifica que se produzca esta recanalización importante del aneurisma con el sangrado de la paciente. Se hace la embolización con coils, rellenando completamente desde el fondo hasta el cuerpo, hasta el cuello, pero parcialmente dejando el cuello libre por la localización del aneurisma en la bifurcación de la cerebral media izquierda. Y este es el resultado, pero el paciente 8 días después hace un vasoespasmo sintomático, recordemos que era un Fisher 4, un Hantiges 4, y se utiliza un sistema que hace muchos años que se había desarrollado para el tratamiento de vasoespasmo, que es un doble balón colocado supra e infrarrenal, o sea, por encima y por debajo de las arterias renales, que lo que hace es redireccionar el flujo sanguíneo de la aorta hacia el cerebro para aumentar el flujo cerebral y con ello la perfusión cerebral, y ven el resultado que se logró después de este tratamiento endovascular con el doble balón coaxia, mejorando el calibre y la perfusión del territorio de la arteria cerebral media izquierda, pero todavía vemos que el cuello está permeable de este aneurisma, por eso es que se decidió seguirlo y un mes después se hace una angiografía de control, que es lo que debe hacerse porque, repito, da la impresión de ser un aneurisma disecante, donde va a haber que sangró y va a haber que reparar este cuello. Y bueno, afortunadamente, desde hace varios años contamos con estos stents diversores de flujo, que seguramente van a ser la solución definitiva para este tipo de pacientes. Este es un SPER-CT donde se muestra los coils de platino, y lo que pueden ver acá es el dispositivo, que es un... Ah, no anda. Es el dispositivo que está colocado ahí, que es un stent pipeline, un diversor de flujo, que cruza completamente el cuello del aneurisma, un 3.5 por 18 milímetros, y pueden ver que al reconstruir el daño de la pared arterial se logra la curación del aneurisma. Como ven acá, ahí está la angiografía digital sin sustracción, la angiografía tridimensional y la y la superposición de imágenes de ambas cosas, donde se ve en el dispositivo el diversor de flujo. Y 15 meses después se hace una angiografía de control, donde se ve la healing line, la línea de curación, que está provocada justamente por la endotelización del diversor de flujo colocado en la cerebral media izquierda, con la permeabilidad de todas las ramas de la cerebral media izquierda y con la oclusión completa, la reconstrucción endovascular que permitió la oclusión completa de este aneurisma, y esta es la angiografía tridimensional de control. Y esta es un poco la tabla de seguimiento. Desde que el paciente sangra, se colocan los coils, se hace el control por angiografía y se coloca el pipeline y se hace el control posterior al pipeline, logrando, como les dije, la oclusión completa.
Bueno, y la paciente creo que anduvo bien, Ángel, ¿no?
La paciente evolucionó muy bien, tuvo su catéter de drenaje, recuperó su vasoespasmo y está actualmente haciendo una vida normal.
Bueno, yo quería, Easy, can you follow us? Did you have the chance?
No, not really. I was trying to figure out how can I switch to English,
English.
but I couldn't.
Well, yeah, I already
but
asked
I
that
understand
question.
that there was a dissecting aneurysm that was coiled first, but came back with recanalization. And then, if you help me.
Yes, the question is, you know, we have to learn about our mistake. So I would like to ask you and the panelists, of course, based on that happens, if you have tomorrow that same case, are you going to start with coils? Are you going to start with stents coils? Are we going to send to neurosurgeon? Or are we going to start with flow diverter? What is your opinion? Let's you have that case tomorrow in your lab in Ankara.
If the patient was ruptured or, presented with a rupture
was
or
an
no?
incidental, was coil, rupture, and the follow-up rupture, retreated with coils, rupture, did a vasospasm, at the very end was treated with flow diversion.
So initially with incidental, no rupture, coiled, but when recanalized, presented with rupture twice, correct?
Right, correct.
And the final treatment was with what?
Sorry, we lost you. Hello? Can you hear us?
Yeah, I see you and I hear you, but I don't know if my voice is going through.
Yes, now it's okay. Now we can hear you.
Okay. So I understand that it came on incidental, not ruptured. After coiling, it recurred and then caused bleeding, correct?
Correct.
Okay, so with dissecting aneurysms, flow diverter works very nicely too. So I think, sorry, Saram, would you please turn off? I'm sorry. I think I could have gone with flow diverter because it was unruptured, so no problem with anti-aggregation and no concern regarding giving anti-aggregation while the aneurysm sac was patent. So I would have probably put a flow diverter in this dissecting giant aneurysm at the beginning.
Thank you, Isi. Well, we have our neurosurgeons here with us, Dr. Russell and Dr. Piroso. Ustedes, conociendo la historia ahora de lo que pasó, ¿qué harían si mañana se presenta este caso? ¿Cuán difícil creen ustedes que es para la cirugía? Para ustedes dos la pregunta, y para ustedes dos también, muchachos, para los tres en realidad. ¿Qué ¿qué haríamos nosotros si se presentara la señora de vuelta con la primera vez con un aneurisma incidental sin haber sido tratada? ¿Quién quiere comenzar? Doctor Russell, lo veo con muchas ganas.
No, he discutido desde el punto de vista de dónde ingresa el paciente. Yo estoy en el interior del país y la realidad es distinta. Hay pocos neurocirujanos que clipen aneurismas. Yo hubiese hecho coiling y después el diversor de flujo. Digamos, es la posibilidad que yo le puedo dar a los pacientes.
Está bien, perfecto. Doctor Piroso.
Yo creo, doctor, que hay que, para contestar esta pregunta, hay que generalizar y no irse puntualmente a un caso y dividir a los pacientes en aquellos que probablemente van a requerir una craniotomía descompresiva o no. Es decir, los aneurismas incidentales de los que sangraron, aún de los que sangraron, cuáles creemos que pueden ir a una craniotomía descompresiva, tratar de ser eficientes en economizarle tiempo al paciente que lo requiere, hacerla, si el aneurisma, además de que el paciente va a necesitar probablemente una descompresiva, va a requerir un flow diverter y va a necesitar antiagregación, yo creo que estos pacientes son candidatos a cirugía electiva en primera instancia. Después todo lo otro es discutible caso por caso, pero creo que la mayor dificultad es complicar a un paciente antiagregándolo cuando después puede ser que necesite una descompresiva y agravar mucho más su situación.
Muy bien. Muchachos, Javier, Esteban, ustedes asistieron a esto. Ahora, si tuviéramos el mismo paciente.
Sí. Creo que con los conocimientos que tenemos hoy, digamos, y por ahí basándonos en las charlas que vimos ya, hoy en día por ahí comenzaría con flow diverter. Por ahí la otra discusión sería si pondríamos algún coil o no para acelerar la trombosis, pero creo que nos hubiera facilitado mucho haber comenzado con el flow diverter de entrada, digamos.
Esteban.
No olvidemos. Está bien lo que dice Javier de hoy en día con la experiencia, ¿no? Pero no olvidemos que esta señora tiene un aneurisma chico, menor a 8 milímetros, incidental izquierdo, y en el año 2008 que no había tanta experiencia con un montón de cosas, tanto intrasacular, diversores, como diversores extra, es decir, flow diverters, ¿no? Así que, no, yo creo que hubiera hecho la misma técnica, quizás asistía con balón o stent, pero hubiera empezado con coils. Acá el problema también fue que la falta de seguimiento, que es una cosa que normalmente a nosotros no nos pasa, ¿no? Y ahí fue que se encuentra la situación de la paciente como vino, ¿no?
Ángel, ¿querés agregar algo?
No mucho más de lo que dijeron. Creo que hay que dividir si son aneurismas saculares y disecantes y si sangraron o no sangraron. Un aneurisma disecante me parece que para la neurocirugía también es complejo de colocar un coil, y entonces me parece que el flow diverter tiene sin duda su lugar, y si sangró probablemente haya que colocar coils en el periodo agudo y después antiagregar al paciente para colocar un diversor de flujo, que es lo que va a terminar de ocluir completamente el aneurisma. Creo que distinto es el escenario si el aneurisma es sacular, donde creo que por ahí en algunos casos puede ser que la cirugía tenga su lugar todavía, pero no en los disecantes, ¿no?
Sí, yo en general, si me permiten decir mi opinión, creo que habiendo asistido a la señora, habiendo asistido a todo lo que pasó, creo que hoy sin ninguna duda comenzaría con flow diverter. Creo que la experiencia es el peine que hay que usar todavía cuando no tiene pelo. Me parece hasta tarde para mí. Así que creo que es importante que aprendamos de los casos. Yo creo que en vista y considerando de lo que pasó, el vasoespasmo severo, lo mal que estuvo la señora, creo que todo lo que aprendimos debe ser de alguna forma aplicado. No en forma indiscriminada, estoy de acuerdo con lo que dice Mariano, todos los aneurismas son diferentes porque todos los pacientes son diferentes, ¿no? Pero yo quisiera aprovechar un segundo todavía que está Isi. Iván quería hacerle una pregunta a Isi.
Yes, yeah. Yes.
Isi, can we ask you a question?
Yes, I can.
Yeah, no, I would like to ask you, myself, if Ivan would like to ask you a question about no flow diverter, but we know that you have a fantastic experience with web. I learned about your experience. So Ivan want to ask you something about web. Can you?
Yes, hi, Isi. Thank you very much for your lecture.
Yes.
After all of the trials that are going on with web, we know that it's a very safe and effective device, but I would like to know if you have any concerns regarding the recanalization rates of web, especially in the long-term follow-up, and if you think that this recanalization can have some consequences or not. Thank you.
Thank you, Ivan. Very nice question. We follow our web cases very closely. Sometimes that recess may show increase in size, but most of the time it stays at some point stable, that we do not do retreatment. But there are few cases in our web series that we ended up retreatment as well. So it is not without any, so to say, recurrence, I would say. But it behaves definitely different than endosaccular coiling. So even though there is a filling at the neck region due to so-called recess filling, in the majority of the cases, it stays stable. So when it stays stable, we do not do anything. There are only few cases with the recess filling becomes larger and larger in the follow-up, then we retreat those cases, and they are very few. So I believe WEP is a very nice device that you do not need anti-aggregation, at least for a long time, because if the case is unruptured, we still put the patient on anti-aggregation, even we plan intrasaccular device in case we need to put a stent or in case we change our plan. But for the ruptured cases, it makes possible to treat a wide neck aneurysm with placing one device, very fast treatment. So I think it behaves differently than endosaccular coil packing.
Thank you very much, Isil.
Well, Isi, when and how often are you using adjunctive techniques when you're using web? You know, now a lot of people are using balloons, stents, even flow diverters when using with web. Are you using often? When you say, well, this case I will do flow diversion, flow disruption and flow diversion. Or in this case, I will use the balloon. We would like to learn about that.
Okay, thank you, Pedro. We use balloon not as a plant most of the time. In case we do not like the alignment of the device, then we may collect and reopen again with the help of a balloon so that we will have a support. Or we may use a stent in case we do not like the alignment of the web, so that we will keep the integrated branch or nearby branch open. We may use stent, but most of the time we use intrasaccular device, the web alone. A reason for that is actually financial and political. What is that? The Ministry of Health does not reimburse stent or flow diverter if we use together to start with. If you use as a salvager, to save the patient, it is okay. But otherwise, we are not allowed, or the expense is not reimbursed. So it is basically related to our own national health policy. There are cases that we used intracellular web plus extracellular intraluminal flow diverter together. Which cases are those? Because at bifurcations, if the aneurysm is large, very large, then it may take time for the aneurysm to occlude, as we all know. So when we worry about a possible rupture with flow diverter only, assuming that, for example, the sac has nipples or it is very irregular, the patient has severe headache, whatever, then in those cases, very selected cases, we used web plus flow diverter together so that we can speed up the reconstruction. It worked very nicely, but we don't have a large series of them. There are only a bunch of patients, I mean, very selected cases.
Well, thank you, Isi. You know, it's something strange. We are on time. Es raro, pero estamos casi les diría que estamos en hora. Así que es mi privilegio ofrecerle al comoderador si quiere hacer alguna otra pregunta o alguno de ustedes tiene algún comentario o quiere hacer alguna pregunta extra, son bienvenidos. Ángel, los muchachos.
No sé si Sachi sigue conectada, ya no.
Sí, yes. Is still there?
No,
Yes.
Is there some cases do you
Yes,
use coils with flow diverter or never you use coils and flow diverter together?
No, we use flow diverter with coils, but at bifurcations, most of the time, there are branches coming off from the sac by definition. So unless if the aneurysm is large and very irregular, we do not put coils together with flow diverter at bifurcation aneurysms because we worry about the thromboemboli with the stagnation and with through the interstices of the coils. So we at bifurcation we do not prefer, except for selected cases, but in the sidewall aneurysms, yes, we do that very commonly for the large and giant aneurysms. Almost all of them, we put coils, giant and large, in the sidewall aneurysms.
Thank you.
Thank you.
Thank you, Isi. Well, thank you very much. We expect now Saro for the next. Thank you, Isi. I think it's probably late in Ankara, so thank you very much for staying with us. La verdad
Thank you.
Las tres conferencias fueron fantásticas, lamentablemente por diferencia horaria hemos perdido a Lorenz y hemos perdido a Bon, pero creo que han sido fantásticas. Vamos a cortar acá, vamos a ir rápidamente a una tanda muy corta y volvemos nuevamente con la próxima mesa. Así que quédense con nosotros, vamos a una tanda, ¿verdad? Gracias a todos. Hola, aquí estamos de vuelta después de este breve descanso. Vamos a enfocar ahora la utilización, la utilidad de los diversores de flujo proximales y distales. Realmente hemos evolucionado muchísimo en esto. Y antes de pasar al doctor Henkes, que va a hablar justamente de aneurismas distales, les vamos a mostrar un caso interesante, Ángel, creo, a ver si lo tenemos disponible.
Bueno, este es un señor de 77 años, hipertenso, dislipémico, diabético, con un stroke previo, con una pérdida progresiva de la visión, con hidrocefalia, y como ustedes pueden ver en esa angiografía tridimensional, un aneurisma disecante de la arteria cerebral anterior. Esta es la resonancia magnética. Como ustedes ven, hay una hidrocefalia, hay un aneurisma que tiene varios estadios de trombo en su interior y hay una dilatación de los ventrículos. Por eso lo primero que se hizo fue colocar una derivación, un drenaje ventricular, y esta es la angiografía por sustracción digital, donde ustedes pueden ver una estenosis severa acá en este lugar. Esa es característico de lo que es un aneurisma disecante de la arteria cerebral media, gigante, por sus dimensiones, casi 20 milímetros, más de 25, y con trombo alrededor, con efecto de masa por la alteración visual que tenía el paciente. Ahí la angiografía tridimensional, donde se ve la estenosis franca, severa, proximal al cuello del aneurisma, y un aneurisma también, una displasia, un segmento displásico de la arteria con otro aneurisma proximal al aneurisma gigante. Y entonces, con un microcatéter se navegó la arteria cerebral anterior y se colocó un stent diversor de flujo, que es un P48, que como ustedes saben pasan por un microcatéter más pequeño, y que el cual se liberó, digamos, cubriendo completamente el cuello del aneurisma. La imagen de la derecha, ustedes pueden ver el vaso CT, y diferentes cortes abajo donde se puede ver la correcta aposición del stent a la pared de la arteria y la cobertura completa del cuello del aneurisma, haciendo ya el signo del eclipse que ya fue descrito hace varios años con la alteración del flujo adentro del aneurisma. Y este es el control 9 meses después, donde ven la reconstrucción perfecta de la arteria cerebral anterior. Como ven acá, donde está colocado el stent, la oclusión completa del aneurisma, el diversor de flujo, mejor dicho, la oclusión completa del aneurisma y la reconstrucción endovascular con la desaparición de la estenosis proximal. Y ese es el control a 18 meses, donde vemos la angiografía tridimensional arriba y el expert CT, el vaso CT abajo, donde se ve correctamente. Y acá la línea del tiempo, preembolización, inmediatamente post, a los 9 meses de seguimiento y a los 18 meses de seguimiento, con la oclusión completa del aneurisma y la permeabilidad de este stent P48.
Bueno, en ocasiones hemos colocado por primera vez algún stent, algún diversor de flujo. No sé si te acordás de este que hicimos en un WLNC, que fue el primero First Men de Fred Jr. Como Nachi va a hablar de esto, queríamos mostrar este caso nada más, que creo que se ve muy bien, como vos decís, la línea del tiempo hasta los 11 meses y el remodeling de la arteria, ¿no? Y como también tenemos en el mismo segmento casos complejos, me gustaría que le cuentes a la audiencia acerca de este caso que realmente dudamos mucho de cómo resolverlo. Primero no encontrábamos el diagnóstico y luego dudamos cómo resolverlo.
Este es un chico joven, 33 años, con una hemorragia subaracnoidea, fundamentalmente en fosa posterior, con un Fisher 4 y un Hanty 2, y esa es la tomografía computada. Si en la siguiente vamos a ver la angiografía digital, después de haber digamos, hecho varios vasos y fue ya el diagnóstico difícil de este aneurisma, porque este aneurisma estaba en la arteria pica del lado derecho y era un aneurisma disecante pequeño. Como ustedes pueden ver ahí, el aneurisma tenía un piquito, que es eso que ven ahí en la angiografía tridimensional. Esa era la disección, eso es lo que había sangrado. Lo que ven es una endomview abajo de una vista endovascular que se hace con la angiografía tridimensional para ver la luz verdadera y la falsa luz, lo que habla de un aneurisma disecante, y la colocación, en este caso de un pipeline, creo que el más pequeño que había y el más corto que había, que está ahí reconstruyendo perfectamente la luz de la arteria pica, quedando justo al ras del origen de la arteria pica, cubriendo la disección y cubriendo ese pequeñito pseudoaneurisma disecante que había provocado la hemorragia subaracnoidea que habíamos visto en la tomografía, en este caso con un pipeline. Y tenemos ahí el post-tratamiento en la angiografía, en la sustracción digital. Y lo más interesante también aún es ver en la resonancia magnética cómo se ve el hematoma, el trombo de la pared del aneurisma disecante en la resonancia magnética pre, y cómo ese trombo, después de colocar el diversor de flujo, se reabsorbe y está completamente reabsorbido el trombo del aneurisma en la resonancia a los 3 meses y a los 7 meses. Ese es a los 21 meses una angiografía por sustracción digital, donde se ve perfectamente cómo está correctamente, bueno, ya está perfectamente hecho y circulado la pica con el pipeline colocado, el diversor de flujo, con la reconstrucción perfecta de la arteria, la vertebral permeable, y cómo se logró poder colocarlo con absoluta precisión hasta el ras, hasta el origen mismo de la arteria pica de ese lado.
Bueno, como también tenemos en este último bloque al doctor Italo Infante, que nos va a mostrar, neurocirujano del Baptist Memorial de Miami, con una tremenda experiencia en aneurismas complejos. Él nos va a mostrar blister like. Así que les queríamos mostrar este blister que tuvimos la oportunidad de tratar, Ángel, ¿te acordás? Con esta masiva hemorragia subaracnoidea, con un Hantiges 3 que volvió a sangrar. No sé si te acordás que la primera arteriografía tenía apenas el blister y en el resangrado se agrandó, así que si querés podés continuar.
Este es el paciente que entonces ven en la primera angiografía, se ve un aneurisma de un tamaño pequeño, un blister-like, supraclinoideo en la carótida interna derecha, pero después al tercer día se ve como ese aneurisma siguió creciendo, siguió aumentando de tamaño, y entonces ahí hubo que ya decidir concretamente el tratamiento endovascular y en periodo agudo y en forma urgente, que en estos casos siempre que hay un sangrado, por más pequeño que sea el aneurisma, hay que intentar colocar coils, que fue lo primero que se hizo, y después, por supuesto, como es un blister y está otra vez lastimado la pared de la arteria, la mejor forma de reparar esto es colocar un diversor de flujo cruzando el cuello del aneurisma en su totalidad, lo cual va a permitir mantener los coils en el saco y reparar el daño del endotelio. Acá hubo que poner 2 o 3 diversores de flujo para ocluir completamente el aneurisma, y esa es la angiografía de control a los 3 meses con la resonancia magnética a los 3 meses y la angioresonancia. Lo que ven allá es un defecto en el flujo provocado por 2 o 3 pipelines telescopados, y esa es la angiografía tridimensional arriba y el vaso CT abajo, donde se ve la perfecta reconstrucción endovascular de la carótida supraclinoidea y los coils colocados a los 3 meses, a los 6 meses con la oclusión completa del aneurisma.
Bueno, si te parece, Ángel, tenemos en sala de espera a nuestros invitados para esta sesión. Está el doctor Hans Henkes de Stuttgart, en Alemania, esperando para comenzar entonces con el tratamiento de aneurismas distales con diversos de flujo. El doctor Henkes es una máquina de innovación. Desde el Solitaire hasta el P64 no ha parado, nos ha deleitado trayendo nuevos dispositivos y conceptualmente enormes ideas. Así que Hans, si estás ahí, nos gustaría que nos digas tu experiencia acerca del tratamiento de aneurismas distales con Flow Diverter.
Good afternoon, ladies and gentlemen. First of all, I would like to thank Professor Lilik for the invitation and for the opportunity to speak about our experience with P48, a new low-profile flow diverter. And as you see from the title slide, which is now presented, so far we have treated 177 consecutive aneurysms. These are my disclosures. I'm a co-founder and shareholder of Phenox and Femtos. And this is the device we are talking about. This is a P48MW flow diverter. This is giving the name 48 nitinol strands, which is made in order to use less side branch coverage. The P48 is accepted by a O21 microcatheter, which facilitates distal access in contrast to 0.27 microcatheters, which are needed for the previous generation of flow diverters. This makes a big difference. It has an independent wire inside, so the wire which is running through the detachment tube and the device itself can be moved independently from the position of the device itself. It can be pushed forward or pulled back. This, of course, offers the opportunity to stabilize the implant during the deployment process, and it allows to pull back the wire in order to avoid distal dissection or even vessel perforation by the wire. This is the summary of our experience. We have, as already mentioned, treated 177 aneurysms, 76 with the uncoated version, and 102 with the HPC coated version. HPC in this context means the implant has a hydrophilic coating, which is significantly reducing the thrombogenicity of the surface of the implant. In the lower part of this slide, you see the breakdown of the aneurysm locations. So only a few ICA aneurysms have been treated. The reason for this is that the largest physical diameter of the P48 has a diameter of 3.9 millimeters. It is a nominal diameter of 3 millimeters. It opens physically to 3.9 millimeters, and this is fitting for only very thin internal carotid arteries. The majority has been treated, or aneurysms were treated in the MCA and the anterior cerebral artery, and a few in the posterior circulation. The majority, again, is middle cerebral artery and anterior cerebral artery, and I would like to emphasize this aspect because these are, at least as long as we talk about the middle cerebral artery, these are typically bifurcation aneurysms, which becomes a further role during this presentation. We started with our experience in November 2016, and we have done cases until recently, and of course, we did the evaluation of follow-up examinations until recently. The registry has 98 patients with 104 target lesions treated with the uncoated version. These were 76 secular aneurysms in 75 patients. The others had been taken out because they were fusiform aneurysms or dissections or anything else, at least not secular aneurysms. These are typically relatively small aneurysms with a diameter below 4 millimeters, and 74% were located in bifurcations. In 57 aneurysms, which is 75%, the flow diversion treatment was a primary treatment strategy, and the remaining aneurysms, these aneurysms had been clipped or coiled or both. Technical results: the far majority of patients and aneurysms have been treated with a single device, so only a few needed 2 or even 3. Complete opening of the device was achieved in all patients, so we had no post-deployment action like balloon remodeling or any other maneuver. We had complete wall apposition, so we didn't need any other measure, and device malfunction did not occur. We had 4 cases with significant foreshortening. This is an important point. Foreshortening occurs more than with other flow diverters, though the operator should be aware that he makes sure to have enough distal and enough proximal landing zone, taking into account that the device upon deployment will foreshorten more than we are used to. Adverse events. We had peri-procedural complications in 9 out of 76 procedures. This is the 12% rate. One was symptomatic, causing a deterioration of the condition of the patient from modified ranking 0 to 1, and the other 8 peri-procedural issues were asymptomatic, like thrombus formation or gastrointestinal bleeding, which didn't cause any permanent issue or something like that. Post-procedural and follow-up complications were those which happened more than 24 hours after the procedure. These were 2. We had 2 asymptomatic issues. The treatment-related change in modified ranking scale was 1 out of 76 patients. The mortality in this group was 0. This is a breakdown of the adverse events. We had 2 asymptomatic sulcal hemorrhages. These, we are not totally sure if these were really hemorrhages. What we saw was on FLAIR MR images a white signal, white phenomenon in the sulci, and as we know from other experience, this can also be related to the administration of propofol for general anesthesia. We had thromboembolic events. 3 were really little small infarcts. The other were just DVI lesions on MR. So they are really frequent. We had 2 transient neurological deficits, 1 minor stroke, 1 gastrointestinal bleeding, 1 asymptomatic paravessel occlusion, and 1 asymptomatic device migration. If you come to the follow-up results, we see after 5.3 months, this was the first angiographic follow-up. We had seen complete occlusion, Remo or Roy occlusion rate of 1 in 39 aneurysms only. Another 17% had only a neck remnant, and 44 aneurysms were, as an aneurysm, still perfused. So complete and near complete occlusion was achieved in 56% of these aneurysms. The next follow-up was more or less after 1 year at 11.9 months, and now we see 72% of complete occlusion or neck remnant, and this does not increase with the next follow-up, which was done at 22 months. So what we see is that something around 70% of the aneurysms are occluded after 1 year, and the others are shrinking in the far majority of cases, but there is still aneurysm detectable. One of the reasons is that, as you have seen before, that many of these aneurysms were bifurcation aneurysms, and we know from experience that in bifurcation aneurysms, especially in MCA aneurysms, even though the aneurysm is going to be occluded, ultimately it may take easily 2 or 3 years to occur. So the reasons for this delayed aneurysm occlusion is that several patients were treated with aspirin and prasugrel for 1 year. They were under dual anti-aggregation for this time. And this, of course, can cause a delayed aneurysm occlusion. As previously mentioned, there was a high rate of bifurcation aneurysms. Again, it may take 2 years or even longer. And intuitively, we obviously had a tendency to oversize the P48, and this is also, since oversizing is resulting in a reduced coverage, oversizing may result in a delayed occlusion. Let's come to P48 HPC. We started later. The first cases were done in January 2018. Again, the latest follow-up data are from November this year. We have treated 135 patients, and those patients had 142 target aneurysms. 101 saccular aneurysms were treated in this group. The others were taken out from this observation, so all dissections, fusiform aneurysms are taken out. 101 saccular unruptured aneurysms in 94 patients. Again, small aneurysms in the range of 3 to 4 millimeters if we look after the mean aneurysm fundus diameter. We had another 83% of bifurcation aneurysms, even higher rate. And for the far majority, for 80%, the flow diversion was the primary treatment strategy. We had in this subgroup 4 clipped aneurysms and 13 previously coiled aneurysms. 79 patients were under a dual antiaggregation and 22 were under single antiplatelet therapy. We again used more or less one device per patient and per aneurysm. The complete opening was achieved in all patients and in all devices. Complete wall apposition was always achieved, and we didn't need a balloon. We had no device malfunction, and since we started later with the HPC coated P48s, I think the learning curve enabled us to encounter only one critical foreshortening with this device. 13% complication rate for symptomatic, asymptomatic. For the periprocedural group of complications, these were 2 hemorrhages, one causing a deterioration of the patient from modified ranking 1 to modified ranking 5. This was I think essentially a via perforation, and we had one patient deteriorating from 0 to 2 and 2 prints, 8 asymptomatic or transient deficits. Post-procedural was 6%, 6 cases out of 94 patients had symptomatic post-procedural complications or complications during follow-up. And the treatment-related change in the modified ranking score was 4, which means 4%, and mortality was 2. One of these 2 patients who died after the treatment. The cause of death, however, was unrelated to the treatment itself. She had another CNS disease and died from this. Breakdown of the adverse events. We had asymptomatic thromboembolic complications, a little less than with the uncoated P48. Transient deficit in 2, symptomatic minor ischemia in 2. So everything you see here is, I would say, in the range of what you can expect. This was a patient, she had a thrombosis with a P48 HPC, despite she was under dual antiaggregation. We gave her integralin. She had a intracerebral hemorrhage in the infarct and eventually died from the secondary intracerebral hemorrhage. This is asymptomatic ICA dissection, and as mentioned before, one patient died from a decompensation of her Chiari malformation. Follow-ups. This 50% rate of a complete or near complete occlusion during the first follow-up. This is again more or less half a year after the treatment, and another 50% of aneurysms still perfused at this point in time. 1 year after treatment, we see 71% occlusion, pretty similar results to the P48 uncoated series, and another 30% of cases remained unoccluded. So these were considered failures, at least seen from the 1 year follow-up rate. We have seen that the P48 HPC can be used, the coated version can be used under single antiplatelet therapy. We have experience with both aspirin for single antiplatelet and prasugrel, and I have to say the antiaggregation with prasugrel only is much more reliable than the antiaggregation with aspirin. So we changed our strategy from single antiplatelet therapy with aspirin to single antiplatelet therapy with prasugrel only. The single antiplatelet therapy obviously contributes to the earlier aneurysm occlusion. If we compare 6-month follow-up in the uncoated group, we have a 56% rate of total occlusion. We have a rate of neck remnant or total occlusion. We have a 35% rate with the HPC under dual antiaggregation, which is much lower, and we see a single antiplatelet therapy associated rate of 71% occlusion after 6 months. So that is what we observed during the follow-ups. Those patients who were treated with the HPC-coated flow diverter and received single antiplatelet therapy usually have an earlier aneurysm occlusion than other patients, especially those under dual antiplatelets. These are a few examples. So this is an unruptured incidental ACOM aneurysm. You see here, wide-necked and certainly not a perfect candidate for coiling. This is a P48 treatment was done in January 2019 with a 3 millimeter by 18. And as I mentioned before, I think it's fair enough to say that this device is slightly oversized. So another choice would have been to use a 2 millimeter device instead of a 3 millimeter P48. And this is in July, half a year later. The aneurysm is occluded and the artery looks just fine. There was also no filling from the other side in that particular case. This is a MCA superior branch aneurysm. It was incidental and was treated in January 2019 again. And this is the device now we use in this smaller artery, a 2 millimeter, 2 by 12 millimeter P48 uncoated in that particular case. And this is the deployed device you see here. The device is well visible. And this is in the fall, in the September of the same year, 9 months after treatment, and the aneurysm is completely occluded. This was a ruptured ACOM aneurysm. The patient was Handel has 1, and the aneurysm was clipped, but there was a significant remnant after clipping, and we decided to deploy a flow diverter underneath the clip and the previously ruptured aneurysm. This was done in April 2017, and as you see here, this is the situation right after treatment, and this is a few months later. The aneurysm is not gone, but you can see this line of white line between the flow diverter and the aneurysm. So we have no recent follow-up for this patient, but I would expect the aneurysm to be obliterated in the meantime. The next case is a spontaneous subarachnoid hemorrhage. It was a 104 fissure 4 hemorrhage, severe spontaneous hemorrhage. The first angiogram was negative. A few days later, a week later, we saw this basilar perforator aneurysm. And this is the 2D angiogram. You see here this little bubble adjacent to the trunk of the basilar artery. You see here, and we deployed under prasugrel only a P48 into the superior third of the basilar artery. This is a 3 by 15. It was treated on January 2nd, 2018. This is the implanted P48 HPC, and this is still January 2nd. The patient was kept under single antiplatelet therapy with prasugrel only, and this is a follow-up in March of the same year. 3 months later, the aneurysm is completely occluded. The patient had a small asymptomatic pontine infarct without clinical symptomatic. So distal aneurysms can be treated with a P48 MW with reasonably good safety margins. P48 is compatible with 21,000 inch microcatheters. The device is user-friendly. It's very easy to use it. The opening behavior is very reliable, and you will always see a very good wall apposition of the implant. The movable wire is an important feature for both safety and efficacy, so you can use it for stabilizing, or you can pull back the wire. And MR follow-up is possible, so the MR artifact is very limited. So in case you want to see the patient during follow-up, it's very well doable to do just time-of-flight MR instead of catheter angiography. The P48 MW shows a significantly more foreshortening if the implant is undersized or if the device is used for treating fusiform aneurysms. This has to be taken account. This foreshortening is, as I mentioned before, it's really different from other devices. And obviously, under dual antiplatelet therapy, the aneurysm occlusion takes longer than with flow diverters with lower porosity. We see this also in the meantime. We started to use P64 HPC, the denser version of the same material and same coating, and these aneurysms have much earlier aneurysm occlusion. And as we observed recently, most of these limitations can be overcome if the P48 is used under prasugrel single antiplatelet therapy. For those who think all these aneurysms are very small, do they really need any treatment? I collected a few cases